Okay. So the topic is electrical impedance tomography. So, so this has been already implemented in practice in Europe countries and Canada, Australia. So, so many of the countries already it's in the practice, but in the Middle East, Asia. So this is actually a new upcoming concept, which is very much essential in our routine clinical routine actually. So I just give you introduction overview about what is this impedance tomography exactly is. I will just give you a basic idea, and then if you want to know about the analysis interpretation of how do we interpret for each specific patients and each disease conditions. So this we will discuss in the later on because I'm not prepared like I did not prepare for the analysis interpretation with this presentation. So I just wanted to introduce this idea. So, like most of you people already might have heard about this electrical impedance tomography, but some of you might not be. So, this will be your first introduction about this new concept. So, we will go into the topic. So, basically, I will cover like what is EIT and what is the concept behind it, how it is works exactly, and also what are the applications that we can use, and what are the advantages we get out of this EIT exactly. So basically, what is EIT is electrical impedance tomography. It's a non-invasive medical imaging technique. So where the electrical conductivity, the impedance, actually the impedance, meaning of the impedance is the resistance for the electricity. So basically, in the image shown with the electrodes with the fixed in the baby's chest. So this can be fixed like this kind of electrode can be fixed any part of the body, and one side of the body is given an electricity. I mean, from the one electrode given electricity, and it is measured as an output all around the specific part actually. So it is a non-invasive medical imaging technique, which is electrical conductivity and impedance measured, and it is shown as a image actually. So it is an additional imaging technology which we are going to use in the daily basis, daily clinical routine practice actually. So this is what the electrical impedance tomography is. So why do we need exactly this as an additional tool? EAT was actually introduced in early 1980s actually by Barber and Brown. So by that time, there was no much aware of this concept, and there was no much of studies also have been done. Also, there was no much practice experience about this EIT. But soon thereafter, it has been used in uh, many categories, like many departments. For example, like gastrology, neurology, and mammogram technology also. So our main focus is on lung function assessment because it has been proven beneficial in all sort of requirements, like all sort of divisions that has been used as the EAT. So why do we mainly focus on lung function assessment is so lung function and the impedance changes. It can be noticed in the real time. So as I mentioned, the impedance is the electrical resistance. So the electrical resistance is continuously varying when there is an inspiration and expiration. So our lung activity is continuous real time process. So where you will notice the changes in a real time and every breath. So that is why we focus on the lung assessment therapy. So our focus on lung protective, actually in our clinical practice. So we are not only ventilating a patient, we are also focusing on the protective ventilation actually. So from the start of the ventilation up to the recovery, up to the extubation phase of this ventilation therapy, we are more focusing on the protective ventilation concept. So as it is shown in the image, you can see first, like we are starting with the non-invasive ventilation. So why do we try to provide non-invasive ventilation? Because we are trying to prevent the intubation. So by that, we are avoiding the risk of ventilator-associated pneumonia, and also it is reducing the length of stay, and also it could be a more cost-effective for the ICU as well. So as we maximum we try to prevent the intubation, so we can prevent this kind of complications that comes along with the ventilation as well. So why I'm showing this image is exactly is this electrical impedance tomography is can be used in the from the prevention phase up to the recovery phase, the complete ventilation therapy, the EIT can be very much useful actually. So when we are focusing on the non-invasive ventilation, so we can visualize the lung image immediately, like what is the benefit out of our therapy. For example, if you want to increase the PEEP or decrease the PEEP, or whether the lung is like a post non-invasive ventilation, whether this lung is really opening up, or it is no improvement after your CPAP or BiPAP therapy. So this kind of visualization can be done in a real time with the EIT actually. So unfortunately, if your patient is already intubated, so there is a chances of ventilator associated lung injury and ARDS, and yeah, so this leads to ARDS, may increase the mortality rate also. So in this, during this intubated period, during this ventilation period, you can visualize the lung, and you can visualize your therapy outputs. So for example, as I mentioned earlier, like your adjustments of the parameters like PEEP, tidal volume, and the pressures, everything can be visualized with the EIT imaging technique in a real time at the bedside. So same goes for the during extubation. So we try to prevent the reintubation. So for that also, it's very much beneficial to maintain this the patient recovery phase continuously. So our what do we really need to maintain these goals of lung protective ventilation is mainly we ensure gas exchange, and as I mentioned, like we need to speed up the weaning process also, because as long you keep the patient on the ventilation, we are more risk of the ventilator associated lung injury and also the infection rate, and we need to treat the underlying cause of the lung disease as well. So how do we do that? So we need to minimize the adverse effects like ventilator associated pneumonia, inflations. So there are different categories of conditions inside the same lung. For example, in one lung, as you can see on the left side, there is a cross-sectional view of the CT image. So you can notice that there is a collapse, there is a cyclic opening and closing, over distension in the same lung. So I will show you what is it exactly. So what is over distension? If your PEEP is too high than required PEEP, so it will cause over distension. So what is happening when you are over distending the lung or the alveoli? So it is already over distended. There is no compliance to ventilate this alveoli, specific alveoli, by and also it is reducing the gas exchange as well. So normal regular alveolus supposed to deflate and inflate, but over distended alveoli already it's kept over distended, so which means there is no ventilation happening inside this alveolus. So what is collapse is exactly, so regular alveolus you can see on the left side, it has to be, as I mentioned, during the inspiration it has to open up, and during expiration it has to uh, come down to this form actually. So but the collapsed alveoli, when the PEEP is too low than the required, it goes to the collapsed stage, which there will be no ventilation in the area at all. So this is collapse. And what is tidal recruitment? So some of the alveoli dependent areas, it will open up when you increase the pressure. When you decrease the pressure, uh, not exactly you decrease, but the during the inspiration and expiration, it is during inspiration it is opening up, during expiration it is completely collapsed. So which means there is a more stress on the alveoli. When it is opening up and closing, it is completely shutting down. So this causes the more stress on the alveoli as well. So as this CT cross-sectional image shows, there is specific part of the lung is over distended. The same lung as this kind of differentiations. So a specific part of the lung has normal ventilation, and some part of the lung has a tidal recruitment, which I mentioned. So when you have the inspiration, it is recruiting. When you have the expiration, it is completely collapsed, and also as well alveolar collapse. So why do we need to look at this right now is because we are just having the global image of ventilation. For example, you get a CT or you get an X-ray, we are just having the global idea of the lung. But what happens after the therapy? For example, you have a patient with the collapse and distension, over distension, tidal recruitment in the same lung. but our therapy is the same thing. Like we do a therapy, but what is the output of it? We don't know exactly. So we need a regional information. For example, regional information is essential. Which part of the lung is collapsed? Which part of the lung is recruited, tidal recruited? Which part of the lung is over distances is essential to monitor to bring the to solve these issues. I mean, to bring the patient out of these issues easily. Okay, so what do we do exactly is we do monitoring of the mechanical ventilations. So as you can see, there is below we have the CT image. So how do we know that this kind of regional information is through, maybe through the CT or MRI, also chest X-ray is shown you. But chest X-ray, as you can see, chest X-ray and CT, it is regional information, but it is not continuous. It is not bedside. X-ray is bedside, but CT, you have to do a lot of work to shift the patient to the CT. And also it is not non-invasive. It is not radiation free because it has ionized radiation. And we have other monitoring capabilities which is lacking about the regional information, regional lung informations. So, but EAT can fulfill all of these requirements. For example, regional information, it is provided, it is continuous, and also it is at the bedside. Non-invasively, you can monitor. Also, it is radiation free because we are just going to provide a small amount of electric signal to monitor this regional information as a lung image. So this is how we do it. Uh, we just place the belt around the chest of the patient to have a cross-sectional view as an image. So as you can see, making ventilation visible is very much easier with the EAT. It is dynamic, real-time display, and also regional information. Each part of the lung is shown you, and also it is at the bedside. It is non-invasive, very much essential. So how it is done? So we are placing the electrodes belt. So it is sending you the electrical signal from the one part of one electrode, and it is measured like this from the each electrode as an output. So what happens is after it's measured, so the each properties of the lung is it has each different kind of resistance. For example, air in the lung has the higher resistance, fluid in the lung has the lower resistance. According to this resistance or the impedance changes, there will be a final display of the specific image. So there is a final display. Also, there is a final view on the screen where you will see as a cross-sectional view of the lung as a final view. So this is just an idea about what EAT is for, and also what is benefit that you will get out of this one as a regional information. So I did not go through how to analyze, how to interpret through this image. I have not included in this presentation. Maybe if you are interested, we can have another presentation regarding this. But I'm sure that this concept you will come across this somehow in the future or recently. So this will be more, beneficial to know about this concept. So when you have a EAT at the bedside, you can immediately see after bronchoscopy, for example, you can immediately see the recruited lung region or the collapsed lung regions when the patient goes through the bronchoscopy procedure. And also when you are doing lung suctioning, so we know that lung suction will de-recruit the lung. So this effect of the lung suction can be also immediately notified through this EAT imaging technology. And also ventilation therapy for the different kind of positioning as well. It is very much beneficial to get a result out of it. So that's it. That's about my presentation. Thank you so much. If you have any questions, we can discuss as well. I hope all of you here.
Yeah. Thank you, Jagan. Thank you, Jagan. It was a good lecture regarding this impedance given by Jagan. So hope everyone learned some new things regarding these topics. So thank you very much for listening, and let us welcome Dr. Arun sir to continue the next session on weaning of mechanical ventilations. Dr. Arun sir is an MD, IDDCM, ADIC. He completed his MBBS in Chidambaram Annamalai Medical College, and then he did his MD in Mahatma Gandhi College in Puducherry. From 2011 to 2016, he joined as a ICU register in at Kovai Medical Center and Hospital. And then he promoted as a ICU consultant in the, from 2016 to 2019, and also a RT in charge of Kovai Medical Center and Hospital. Then he got opportunities in Hamad Medical Center. From 2009 to present, he's working as an ICU specialist in Hamad Medical Center. So I warmly welcome Dr. Arun sir to give a lecture regarding this mechanical ventilation. Welcome, sir.
Thank you, Kannan. Thank you for the introduction. First of all, I would like to thank the RT group or the society in Coimbatore for giving me such an opportunity. And I thank all the RTs for rendering their support during this COVID pandemic. It has been a tough time, but with all of us working together, I think at least in Qatar, we have brought the COVID under control. So I hope soon back in India with all your supports, all your colleagues, I think this COVID pandemic will be, under control soon. So today quickly, I will go into the topic. So today, I didn't prepare anything, different. This is a routine topic which we have or you have heard so many times. So it's just a basic topic, but I felt it is an essential topic. How many times you read or how many presentations you attend, there is something new in every presentation. So I have done my best. I have made it simple, and I have even learned myself some new concepts. So we'll go into the presentation. So my topic for today is weaning from mechanical ventilation. So basically, ventilator discontinuation process is an essential component of overall ventilator management. As you know, see, it is not just ventilating the patient. It is not just helping in intubating the patient. The whole process, right from the patient gets intubated till he gets extubated and post-extubation care, all comes under ventilatory management. It is not just managing the ventilator. So everyone should be aware of weaning any patient on a ventilator. As you all know, any undue delays in extubating the patient or weaning them from ventilator can cause excessive stay. That might add to cost. It can cause iatrogenic lung injury. Being in ventilator, he might require sedation, and all this can lead to high mortality. On the other hand, if you prematurely withdraw a patient from ventilator, prematurely extubate a patient or try to wean him, that can lead to muscle fatigue, hypoxia or hypercapnia, or loss of airway protection, and ultimately results in higher mortality. So how is weaning done? So basically, weaning is a three-step process. It starts by assessing the readiness, next the weaning itself, and the last, the extubation part. So what is readiness? In simple terms, readiness is nothing but you determine whether a patient is ready to be weaned from mechanical ventilator. So basically what you do is you have certain clinical criteria. You see the clinical criteria, and then if the patient fits the clinical criteria, you deem that the patient is ready for weaning. Second is the weaning process per se. So weaning is nothing but you are gradually reducing the support from the ventilator so that the patient starts to breathe by himself and he is getting ready for extubation. Extubation, the last process, is nothing but the removal of the endotracheal tube, which nowadays is called as liberation from mechanical ventilator. So as I said, how do you determine the readiness? So how do you say the patient is ready for extubation? So as I said, you have certain clinical criteria. So once you go through the clinical criteria, once the patient is fitting in to one of those criteria and you feel he is ready, you can always start the weaning process. So basically, the required criteria is the causes of respiratory failure has improved, or you can say why the patient is being ventilated. Someone who came with pneumonia, with severe hypoxia, he might have got intubated and he would have been ventilated. Or sometimes respiratory failure may be due to some OPC congestion, ingestion, and patient develops severe muscle weakness, respiratory failure, is not able to ventilate properly, poor muscle power. Probably he would have got ventilated because of the respiratory muscle weakness. Or sometimes trauma. You might get a patient who had severe trauma, unable to protect the airway. He is in a risk of aspiration, low GCS. So probably he would have got intubated. So what you have to see is whenever you are planning to see whether a patient is ready to wean, you should see the first criteria is why he got intubated and whether that problem is solved. So for example, if patient is intubated for pneumonia, then obviously what you have to see is whether he is oxygenating well, whether his primary cause for intubation is solved, or whether the primary cause is resolved. If someone is getting intubated for a low GCS, then obviously what you have to see is whether his GCS is better. If someone is got intubated for low muscle power or weakness, in case of GPS, then obviously what you have to see is whether his muscle power has improved. Okay, that is your primary criteria. Next is your PaO to FiO ratio. So ideally it should be more than 150, and the patient should maintain a saturation of more than 90. I would recommend more than 94 with an acceptable FiO2, at least minimum of 40%, and he should not be having a higher PEEP. The desired PEEP will be at around 5. And next is this pH. So whenever you see whether the patient is ready for extubation or ready for weaning, you have to see the pH. So pH plays an important criteria. As you all know, if patient is having a pH of less than 7.25, then obviously he is acidotic. Either it can be a respiratory acidosis or it can be metabolic acidosis. So both can affect oxygen demand and oxygen requirement. So patient obviously will be tachypneic. He will not be, once you start weaning, definitely he will not tolerate the weaning trial. So anyone whose pH is less than 7.25, you are not supposed to wean the patient. The main thing, another main thing is the hemodynamic stability. As I told you, patient should be hemodynamically stable, because if patient is already breathing at 30 rate, and if his blood pressure is 90 over 40, and is already tachycardic with a rate of 120 130, what will happen is whenever you try to wean them, the respiratory muscle fatigue will further worsen the hemodynamics, and the chances of even cardiac arrests are very high. So whenever you plan or whenever you see whether patient is ready for weaning, you should see that the patient is hemodynamically very stable, and at least he should be in minimal dose of vasopressors. We cannot wait till they completely stop the vasopressors, but at least if he is on one vasopressor, for example, low dose noradrenaline, like 0.1 to 0.2, yes, you can go ahead and start weaning this patient. And main other thing is he should to initiate an inspiratory effort. Otherwise, there is no point in attempting a weaning trial. So there are some other additional criteria, which includes hemoglobin that should be more than 7, because Obviously, the oxygen carrying capacity depends upon the hemoglobin, and the patient should not have temperatures, extremes of temperature. It should not be cold, or he should not have fever. Again, fever, it is like a relative contraindication. It is not an absolute contraindication of weaning. And again, the mental status. It is also an optional criteria, because sometimes, patient might be very agitated, so we might have to wean him with little bit of sedation. So just because patient is a little sleepy or drowsy doesn't mean that we cannot wean a patient. But all these criteria are just, it depends upon the clinician and the RT or whoever is on the bedside. These are all, just a guidelines to us to decide whether he can be weaned. The rest is up to us. For example, you can, if patient is little drowsy, but he can trigger spontaneous breaths, obviously you can start weaning this patient. Or if, example, patient is having a mild temperature and you feel that's all right, you can start weaning the patient. And other things is like, if patient is slightly tachycardic, heart rate of around 100, 110, and you feel, this is all right, obviously you can, start weaning this patient. But what is important is you have to see, like, whether whatever intervention you are doing, whenever you are trying to wean this patient, how do they tolerate the weaning? That is what is more important. So we'll discuss that in subsequent slides. So as I said, weaning can be simple, or it can be a difficult weaning, or it can be a prolonged weaning. Simple weaning is nothing but, you start weaning a patient, you give us spontaneous breathing trial, and then you take off the tube. So that is simple weaning. So difficult weaning, what does it mean? You might require almost 3 spontaneous breathing trials, or you might take a week to wean this patient. So these patients fall under difficult weaning category. Prolonged weaning is patient fails almost 3 spontaneous breathing trials or requires more than 7 days to wean. So that is how weaning is classified. Most of the patients will fall under simple weaning. Most of the ICU patients. Only few, like around 15 to 20%, might fall under difficult weaning, who might require 3 or more breathing trials and who take almost 7 days to wean. Prolonged weaning, of course, trauma, severe sepsis, patient with severe CIPN, neurological manifestations like stroke, intracranial hemorrhage, tracheostomy. So those are patients with severe ILD who got intubated. So these patients are a little challenging and they might take more than 7 days to wean. So this is just a diagrammatic representation. I have not done anything much. Whatever I have told, I have just put it as a small, graphical representation. I don't think, there is nothing much from this slide. So moving on. Okay, now you have assessed the patient. Patient is, ready for weaning. You wanted to wean the patient. So how do you want to start weaning? So preferably, whoever is intubated for more than 24 hours, you should assess whether he is ready for weaning, and if he is ready, you should start weaning trials. And this weaning trials has to be on daily basis. In every institution, every hospital should have a definitive weaning protocol. So there is a meta-analysis of 8 trials, almost 1,000 patients, where they found out when they had a protocol, and when they did a daily spontaneous breathing trials, the mechanical ventilation duration is reduced by almost 16%. So every institution should follow a weaning protocol. They should stick to the protocol, and they should initiate this protocol whenever possible. So, okay, you have assessed the readiness to wean, and you have decided to wean the patient. So what mode you want to start with? Ideally, all the patient, mechanically ventilated will be on some control mode. Either he will be on volume control or pressure control, or some of the newer modes. But preferably weaning modes, what they say is with multiple randomized trials, what they have found out is CPAP with pressure support is the best weaning mode. The other weaning modes include intermittent mandatory ventilation with pressure support ventilation. So basically, it is a pressure support weaning. So what you do is, you in pressure support weaning, you initially set a pressure between 12 to 18. Preferably, you start with higher pressures and you target a spontaneous respiratory rate of less than 25 breaths per minute. The pressure support ventilation or the pressure support is gradually reduced by 2 to 4 centimeters of water once or twice a day until you reach a lesser pressure support. Say, for example, around 5 to 8. It can be more rapid or you can gradually reduce the pressure support depending upon how the patient tolerates. Basically, when you do this, you should keep up positive expiratory pressure, which is normally at around 5 centimeters of. So what is this intermittent mandatory ventilation? So we always know that SAMV or synchronized intermittent mandatory ventilation is one of the winning modes. But I have been using this when I was doing my post graduation during my anesthesia days. But once I started ICU practice, we never used SAMV. Though there are some advantages, this mode has some disadvantages as well. So basically, what they do is they initially set a respiratory rate. Obviously, this the machine will definitely mandate ventilation, and if there is anything, if patient is not triggering or if he is not taking up a breath, the machine will support. So gradually, what they will do is from 8 to 12 breaths, the support breaths, they will gradually reduce the breaths. So that when the patient is requiring minimal support, obviously it means patient is tolerating the spontaneous breathing intervals. So whatever may be the mode, daily spontaneous breathing trials or SBT is very important. So whenever you feel that the patient is ready for weaning, every day you will have to give a sedation occasion and you will have to try for a spontaneous breathing trials. So as I said, in SBT, the patient breathes spontaneously for a set period of time. The SBT trials can be as short as 30 minutes to almost 2 hours. And sometimes you might need a prolonged SBT trials where you feel that patient might have a failed extubation or, he might need, more assessment regarding his respiratory muscle functions. But in cases of, cardiogenic pulmonary edema or in cases of COPD, type 2 respiratory failure, you will have to give a little prolonged spontaneous breathing trials so that you can clearly assess whether the patient is, will tolerate extubation. Almost 50 to 75% of patients who pass initial spontaneous breathing trials are capable of successful extubation. So what do you do? What will happen if patient fails the initial SBT? So all the patients who undergoes initial SBT will not pass. At least 20 to 30% of patients will fail the initial SBT. So what you have to do is continue the weaning with daily SBT, preferably CPAP with pressure support rather than SAMV mode. This is all by the random trials that has happened. And while you wean the patient, there should be a strategy for extubation. Sometimes, you might need to extubate the patient directly through an NIV because they already failed the initial SBT. So whenever a patient fails an initial SBT, you will have to be very careful because the chances of extubation failure is very high. So basically, SBT is nothing but some form of an ventilatory support, low level pressure support with some tube compensation along with a continuous positive pressure rather than no ventilatory support. So what should be your ideal SBT duration? How much time you want to perform? Ideally, spontaneous breathing trials can be performed up to 30 minutes to 2 hours. As I told you earlier, in some selected patient, it has to be prolonged for much longer time. It is up to our clinic. So the optimal duration of SBT is uncertain. It depends upon the underlying reason for intubation, the duration of mechanical ventilation, and institutional and physician practices as well. Because most of the patients who got intubated or ventilated for some procedure, mainly in anesthesia, we don't do SBT trials for half an hour or 2 hours or 4 hours. Whatever we do is just once the patient is out of the relaxant, when he started to breathe, if he is generating adequate tidal volume, if he is trying to protect his airway, and if you feel he is all right, we just extubate the patient. So the ideal duration of spontaneous breathing trials is uncertain. It depends upon the patient. So general approach is like, if patient is mechanically ventilated for less than 24 hours, ideally, sometimes you might need not have a SBT trial. Just 30 minutes of SBT is acceptable and you can extubate this patient. If patient is falling under something like 1 to 10 days, less than 10 days, you can start with 30 minutes to 2 hours. And if it tolerates 2 hours of SBT, obviously you can extubate this patient, or at least he is ready for extubation. More than 10 days, still 30 minutes is sufficient. However, it is an individual approach and we might need to extend the duration of trials. So what I'm trying to say is, first thing is, every day a patient has to be put on spontaneous breathing trials whenever possible. And whenever he is tolerating the SBTs, what you have to do is, you have to see how long he tolerates, and the duration of toleration depends upon his clinical status, his clinical condition, whether he is tolerating the SBTs. So those are the things that you have to keep in mind. So whenever you put a patient on SBT, you will have to assess whether the patient is, the weaning process is successful or whether it is a failure. So you saw a patient, you felt he is ready for weaning, you have put him on a weaning mode. So what you have to do? First thing is, you have to monitor the vital signs and ventilatory parameters. So vital signs might include from your heart rate, respiratory rate, obviously blood pressure, and when you start the ventilation weaning process, patient might be tolerating the weaning process for some time, and then after a while he might become more tachycardic, he might become more tachypneic, he might become hypoxic, he might become irritable. So you have to closely stand by the patient and you will have to closely monitor what is happening to the patient when you start the weaning trials. And of course, you will have to set the ventilatory parameters, set the ventilatory alarms properly, so that if there is anything, or if there is any mistakes, or if there is any issues with weaning trials, that should prompt you and you should immediately go and attend. So this slide is just to show what are the things that you have to monitor. And of course, you will have to see the patient, you have to see whether he is breathing properly, whether he is using any accessory muscles, whether he is having any indrawing of intercostal muscles, or whether he is breathing by having an abdominal breathing. Those things have to be monitored. I mean, even sweating can be a sign of fatigue. And other things you have to monitor is this ECG, where sometimes patient might have a silent ST elevation, STT changes. They may develop an arrhythmia. So basically, when you do something, obviously you'll have to look for the consequence. So you are putting a patient who is on ventilator for a considerable period of time, and suddenly you are taking out the support. So that might have an impact on the physiology. So you will always have to look at the changes that is happening. And at the end of each spontaneous breathing trials, you are supposed to do a blood gas just to see whether a patient is having a normal blood gas, whether he is hypoxic or whether he is retaining CO2s or whether he is having acidosis. So what is happening, because you have given a trial, so you will have to periodically do an ABG and see. So that is what I told you. So how will you identify a patient has failed weaning trial? So clinically, you have to look for nasal flaring, increased respiratory effort, tachycardia, cardiac arrhythmias, hypotension. The laboratory criteria includes, pH of less than 7.32, or a decline of arterial pH of more than 0.07, and if PaO2 is less than 60 with a minimal, FiO2 of 40, and if there is a fall in oxygen saturation of more than 5%. So all this criteria tells you that this patient has failed these spontaneous breathing trials. So how do you say this patient is ready, or if you give a spontaneous breathing trial and you feel that patient is successfully passed the spontaneous breathing trial? So how do you say, or how do you predict, or how do you decide? So we have again some parameters which can tell us that this patient has successfully passed the spontaneous breathing trials. As I told you, patient has to be, hemodynamically very stable whenever you start, and whenever you give weaning trials as well. So now here are these parameters to show that this patient has successfully, tolerated the spontaneous breathing trials. So the respiratory rate ideally should be less than 30. I don't see that, somewhere around 38 it is mentioned. I mean, definitely no. Ideally it should be less than 30. And tidal volume, of course, you should be able to, generate at least 6 ml, 4 to 6 ml per kg. And, minute ventilation, as you all know, 10 to 15 liters per minute. And, force, what you always, see whether a patient has an adequate muscle power to generate. That should be around -20 to -30. And maximal inspiratory pressure should be, minimal inspiratory pressure, that should be around -15 to -30. And ideally, what we do is this RSBA, rapid shallow breathing index. So that should be, less than 105. So if patient has an RSBA of less than 105, they have a very good success of extubation. And other scores include the CROP score, which looks into your compliance rate, oxygenation, pressure. So that should be, or the desired value should be around 30. Okay, there are other parameters as well to assess whether the patient is patient can be successfully weaned, or whether he can tolerate weaning. One is this compliance. Now recent ventilators, you can directly measure the compliance. So static compliance is nothing but change in tidal volume by change in pressures. So whenever you do a compliance and see, and if there is a static compliance of less than 33 ml per centimeters of water, patient had a poor tolerance to weaning trials. Next is your work of breathing. So work of breathing can be calculated, from the tidal volume and intrathoracic pressure. Again, it is an invasive measurement. You should need a esophageal balloon. By this you can calculate the work of breathing. However, the precise value to discriminate whether this patient will tolerate extubation is not, clear. The other parameter is oxygen cost of breathing. So this is nothing but the difference between total oxygen consumption during spontaneous breathing and during relaxed mechanical ventilation. It again needs a special requirement. You need a metabolic chart. You have to, and it differs according to the clinical status and physiological status of a patient. So this is not routinely available in most of the ICUs. But ideally, the value is if the oxygen cost of breathing is less than 5% of total oxygen consumption, it means the patient is healthy and we can wean this patient and extubate this patient successfully. The other is the occlusion pressures. This respiratory drive can be estimated by measuring the airway pressure in the first 0.1 second during an inspiratory effort against an occluded airway. It should be ideally less than 2 centimeters of water. Whenever this occlusion pressure values are high, greater than 3, they are associated with weaning failure. And again, as I said, maximal inspiratory pressure, which we usually called as MIP, it should be around -30 or less. That is more negative, where we will have a successful weaning. As I said earlier, the rapid shallow breathing index, the RR by the tidal volume, it should be ideally less than 105. And there are other, parameters like inspiratory effort quotient, crop index, core index, weaning index. So I'm just trying to, skip this because, it is all calculation. But the easiest thing is, everything has a value. So if you know what is the ideal value, obviously you can calculate. And then, if the patient successfully has a score of, whatever the desired score is, then obviously it means he has a successful weaning rate. So what I would suggest is, all these are just, numerical values. You cannot always go by the value, though it can give, a hint about the weaning failure. For example, you might start weaning a patient and, he might be little tachypneic. His heart respiratory rate might be around 33, 34 when you give a spontaneous breathing trial. So it doesn't mean that this patient cannot successfully extubated. Or sometimes when you start a weaning trial, suddenly patient, might become, hypertensive, his blood pressure might go little high. So though there are some, changes in physiology that can augment all this, it always doesn't mean that these patients cannot be extubated or this patient will not successfully tolerate extubation. But these are all, you will have to see all these values and numbers holistically, and it has to be individualized depending upon the patients. And coming to weaning failure, as I told you, whenever the patient fails the initial breathing trial, he should be put back into the spontaneous breathing trials, or at least to previous ventilatory settings. At least for some time, you should not try to wean these patients. Give some proper rest. Ideally, 4 to 5 hours of rest, and then again you can start back the weaning. But again, as I said, it is not hard and fast rules. Sometimes when you try to wean a patient, he might be on sedation and he might not be fully out, so he might not trigger the ventilator. So it doesn't mean that you cannot wean him again. So you can switch or control him back on the ventilator, give some time, and the same day in another 2 or 3 hours again you can try to wean these patients. So these are some of the causes for failed weaning or weaning failure. It can be a pulmonary cardiac cause, or sometimes electrolyte abnormalities. As you all know, pulmonary causes include increased airway resistance. The patient might be in a smaller size tube, and you might probably try to wean him. Even SBT trial, he might not tolerate because the airway resistance is too high. Or in patients with severe ILD, or patient who are recovering from ARDS, or who are having severe pneumonia, there might be a decreased lung compliance. Even a patient ventilator dysynchrony, you select an inappropriate mode of weaning, or patient is very agitated. He sometimes you might need to put him on some low dose sedation. So even a small patient ventilator dysynchrony can cause a weaning failure. And this pre-existing cardiac disease, like heart failure, whenever you try to wean these patients, they will suddenly go in for pulmonary edema. So these are some of the causes, and central cause includes decreased central drive, and other causes include severe metabolic alkalosis and high sedatives. And electrolytes, of course, it is very important. All your trace elements, potassium, phosphate, magnesium are very important. So every day you will have to look into these numbers, and you will have to ideally correct. And again, in ICU, we use steroids, and that it can cause severe myopathy, and the patient muscle power might be very poor, and he might not be able to adequately trigger the ventilator. And malnutrition, of course, and overweight. These are all some of the causes for weaning failure. So what is the weaning success? Weaning success is nothing but patient has successfully passed the weaning trial, and at this point you will have to have a clear plan to how to extubate this patient. You will have to assess whether it is going to be a direct extubation, or whether this patient will have post extubation complications. So you started with the assessment of readiness to wean, then you gave a spontaneous breathing trial, then you assess whether patient has tolerated your SBTs. You had a parameters, you had various numbers, indices. So you look into all this, and then finally you decide this patient has passed the weaning successfully. So extubation is nothing but a removal of the endotracheal tube, and this is the final step. And it should not be performed until it has been determined that the patient medical condition is stable, a weaning trial has been successful, and the patency of the airway and any potential difficulties in reintubation has to be identified. So in brief, patient should have stable medical condition. He should have successfully passed the weaning trial. You should be able to assess the airway. You should know whether patient is having adequate cough strength and secretion clearance. If you have a spirometry, you can test and then find out. Patient would have an good mental status, at least GCS of above 8. You have to assess for post extubation stridor. You should have a good cuff leak. I mean, this cuff leak is not a mandatory test, but of course you should know whether a patient will have a difficulty post extubation. At least you should be knowing whether patient is having a cuff leak or not, because once you when the patient doesn't pass a cuff leak, it means that the chances of stridor or post extubation stridor is very high. And nowadays you have laryngeal ultrasonography, where you can assess the cuff leak during the ultrasound as well, and you can assess simultaneous cuff leak and cough by deflating the cuff, occluding the tip of the endotracheal tube, and asking the patient to cough. So once you assess patient is ready, Ideally, the next thing is to extubate this patient. And who are all the high risk patients who can fail? So ideally patients with poor cough, peak expiratory flow of less than 60, or patient who needs frequent suctioning, sputum value of more than 2.5 ml per hour, or if patient Glasgow Coma scale is less than 8, a positive fluid balance in the last 24 hours, or if there is the cause for intubation is pneumonia, my patient is elderly with severe COPD or cardiac illness. These patients are high risk for developing post-extubation complications. So whenever you plan to extubate the patient, or whenever you start weaning a patient, you should keep in mind that this patient, once extubated, might have one of these complications. So you'll have to always evaluate the risk factors also. So coming to the last part, you should have a proper plan. You should have extubation equipments, which includes your suctioning, your reintubation kit by the bedside, the nebulizations, the oxygen, supplemental oxygen method which you are going to deliver after extubation. Everything you will have to plan. You should not, it is not just removing the tube. You will have to plan adequately. You will have to have a, plan for reintubation. Anything can happen. The patient might have successfully passed the SBT, but still he can fail the extubation. Positioning, of course, most of the times we extubate the patient, in upright or propped up position, and in some instances, like for example, some surgical procedures where they have, spinal surgeries, or the procedures which doesn't allow them to sit upright, then obviously we'll have to remove the tube in slightly lateral position. Before removal, as you all know, you have to suction the airways, make sure that the airways are clear. You will have to tell the patient what you are going to do and what is going to happen. And once things are ready, you can extubate these patients. As I said, post-extubation management, you should always have an idea what is going to happen. You should always anticipate. As clinicians, we should never take things for granted. You should always think about the complications that can happen. So whenever you plan and extubate a patient, you should always think about the post-extubation complications, and you have to be ready. And these complications can happen immediately, and it can happen anytime within the first 24 hours. So always you should be ready with your backup plans. Thank you for the opportunity. I think I tried my best to at least give some idea about what is weaning and how it is being done. And once again, thank you, Dr. Nandakumar sir, who is taking all initiatives and keeping up the good works and spirits. I thank Dr. Nandakumar sir again, and all the respiratory therapists, Satish, Tulasi Raman, and everyone for giving me this opportunity. And I'm looking forward for some more presentations. Maybe if time permits, we can all meet up again together. Thank you.
Thank you, sir. I think it was a good and clear explanation regarding this weaning from the mechanical ventilations. Even though it is already known topics, but we gained, I think, hope everyone gained good good additional things to update ourselves and to improve our knowledge. Thank you, Arun sir and Jagan, to give this opportunity to attend your speech and lectures. So thank you, Arun sir. Thank you, Jagan.